What's up, everybody? Welcome back to my channel, Real Talk Recovery, where we talk about recovery from addiction and I share my life with you. My name is Nicole and I am an addict, and my sobriety date is July 13th of 2015. And today, you guys, we got a special treat. Dr. B is going to come on and answer questions and just hang out with us today. So I'm just waiting for him to come on. He's getting himself washed up and ready, so he should be here shortly. Y'all come on in, have a seat, greet your neighbor, drop your sobriety date down in the comments if you're on Suboxone or Methadone. Let me know how you're doing on that. If you're tapering, if you're not tapering. If you have any questions, let me know. I've got a few questions that I had sent in from you guys. I think, Diane, I have your screenshot question that you left on the community tab. Let me see. It's this one right here. Fluctuations of ceiling effects. Hey, Nancy. Hey, Sky. Hey, Seth. Hey, Beast of Burden. Hey, Danny. Yay! I'm so happy y'all are doing so good. That makes me so happy to hear that, you guys. For real. Yeah, are they over there on his community tab? Because I'm going to pull them up when he gets over here. In fact, okay, if any of you guys are in any maintenance medication support groups or like on Reddit or Facebook, would you guys do me a solid and share this video real fast? If you're in any area like the Reddit, I know, Diane, I couldn't believe it. I was so happy to see that you did that, because sometimes they get upset with me whenever I share my own videos. So I've been trying not to just share my own videos over there, because I don't want anybody to think that I'm trying to I don't know, I'm not, it's not about me self-promoting. It's about me letting people know that they can come over here and ask questions, because you guys know how I am. Diane, I have your question pulled up right now, so that way I'll be ready. And then I have Heather Couch's question pulled up. So I got you guys' questions ready. And just hang tight. You know how Dr. B is. He'll be here shortly. Hey, Austin. Austin, I was watching one of your hot sauce reviews the other day. I don't know how I fell upon that video, but I think it was on Facebook, and I was just like, oh God, I cannot eat that really hot stuff. It makes my stomach hurt so bad. But thank you, Diane, for sharing that video over there. I didn't, you know how it is. I just want to make sure that I'm abiding by the rules. So it always helps whenever you guys share the content for me, especially in other people's groups and stuff, because people can be weird about that sometimes. Hold on. I'm going to share over on my community tab. So y'all hang tight. Just chill with me. Just chill with me. We're hanging out. How does everybody's day going? Did everybody have a good day? Are y'all staying on the straight and narrow, staying sober? Okay, I'll tell you how to do it, Diane. Look underneath the video right now. Click out of this chat, and underneath my video, you will see an arrow. Press that arrow, and it'll share it, and then it'll pull up your. In fact, I can do it right now. I'll do it. Don't worry, girl. I got it. So happy I made it. My phone hasn't been notifying me, so I always end up watching the replay, but I can never see the chat replay even hours later. Oh, Beast of Burden. Do you know what's been going on, you guys, on YouTube? It's taking them like half a day, over 8 hours, to upload my live streams. So like right now, it's the best thing to do is, if you can get to these live streams at 7 when we go live, is to be here for the live, because a lot of what's happening is it's literally taking like 24 hours. Okay. What's up? I see Dr. B.
Hi, Nicole.
Hey, what are you doing?
Good.
Dr. B, I have to tell you something. I've got tie-dyed masks now, so I'm going to send you one out there.
Okay.
You're going to be the coolest doctor in California with your tie-dyed mask. Okay. So are you ready to rock and roll?
Yeah, are we alone in here?
No, there's 23 people.
Oh, I was going to talk about some problems. Okay, good. Thanks for telling me because I don't see anything.
Yes, we are live. We are live.
And there was some comments. I've been so busy, but oh my God, there's a lot of people. There's some comments that and I'm sorry, I've been so hammered. But Austin was asking me some questions, so I'm sure you got it all. So I'll let you go. Go ahead. Hi, guys.
I got it all. I got it all for us. Okay, so we'll start out with the questions. Then I was going to kind of wanted to get your opinion on some things. So here we go. First question, Dr. B. So it says, Dr. B, I saw this post and wondered about the truth of it regarding fluctuations and ceiling effects. So here's the post. I'm going to read it to you, okay?
Okay.
Honestly, 20 milligrams is good to stabilize on because you were above the ceiling limit where you don't feel the up and down fluctuations in your bloodstream because they are so tiny. That allowed you to live a normal life. Shouldn't be taken for granted. You didn't trade one addiction for another, and you didn't even trade one dependence for another. You've got the same opioid dependence you've always had. Doesn't matter if you're taking heroin, Suboxone, or Oxy. It's an opioid dependence. Taking Suboxone doesn't change the status of your dependence. What does, however, is eradicate the addiction. There is a huge difference between dependence and addiction. That being said, if it's time to get off, then it's time to get off. But you weren't stupid for taking that much because that much is necessary to ensure your blood levels don't fluctuate, which causes highs and lows, which ensures your addiction stays with you. By taking enough to stabilize, you have eradicated the addiction and can now work on addressing the dependence. The same dependence you've always had the minute you decided to start using heroin. Suboxone doesn't cure dependence, it's addiction. Dependence can be managed. Addiction cannot.
I'll break it into different parts. I love the way she separated addiction, except I wouldn't call it, I'd be careful calling that thing dependence. I'm more comfortable. I love the way whoever wrote that wrote, you already had the addiction. I wouldn't say you already had the dependence. I could say the addiction. And dependence is, I wouldn't use the word dependence as a catch-all. But they did a great job at describing this issue of difference, except the term dependence. You know, they are right. You are already physiologically dependent on the opiate. But you're also physiologically dependent on certain medications that you may need. You could argue that you are dependent on insulin, right? And it is
right.
True. But because dependence has so many negative connotations, and because they're using it as a very narrow definition here, because they said something at the end, you've cured the addiction or you've taken care of the addiction, now take care of the dependence. That really muddies the waters, because when you're trying to treat the addiction, it's not step by step or goes to a dependence. Dependence is purely mechanical and physiological, and addiction is a more higher functioning issue at its root, and it's complex. So they partly did a wonderful job of separating that you are not an addict if you take Suboxone. I love that. The part that is completely wrong is the 20 milligrams. You're supposed to titrate the dose up to effect, and that effect is not at 20 milligrams. It might be 32 milligrams, and the ceiling effect, and that's only a physiological theoretical ceiling effect, or rather a pharmacological theoretical ceiling effect, is 32 milligrams. And what at 32 milligrams in theory, and I say in theory because I need a super microscope to look at every receptor, and it's going to be off with a plus or minus degree of statistical error. At 32 milligrams, you've pretty much saturated all the receptors so you can't overdose. But what they're trying to say is that it's leveled out in the blood, true, but that's not necessarily 20 milligrams. It's whatever you're at, and for each person, because of their number of receptors and physiology, it's different. So you titrate up. So I just recently, yesterday, titrated up a family. They're related, two family members. They both showed up, and their drug of abuse was oxycodone that they were buying on the street. And for a second, and foolishly, I didn't think it was not going to need much to get them stabilized. It actually ended up taking me a day and a half to titrate up because I do it myself. I don't send people home. I do it myself, and I watch it closely. Do you know how much it took? 32 milligrams for these guys to stand. They're not lying and they're not cheating. So it's different with everybody. And the theoretical pharmacological ceiling is 32 milligrams. I have patients on 1 milligram twice a day. I have two patients on 40 milligrams a day. And the one that's on 40 milligrams, a little bit of it is psychological, but as long as they're under my supervision and I watch and control it, I'm okay with that.
I have to tell you something. I've dropped down, to 2 milligrams, and I take 1 milligram in the morning, and I take 1 milligram in the afternoon. And my husband is prescribed, like he's on 20 milligrams, and he's not going to get off, but I'm tapering off. The other day we were at his mom's house and I had forgotten to take my medication. So I was like, hey, did you bring your Suboxone with you? I haven't taken mine today. And like, not even thinking about it, Dr. B, just thinking I'm going to take a half, which is 1 milligram, like on my own, right? I took that and I was like, oh my God, this is 4 milligrams. And just from being on 2 milligrams instead of taking 2 milligrams and taking 4, it was like such a big jump up that I could tell that it was like, you understand what I'm saying? Like I could tell that it was different. And I told my husband, I was like, wow, I'm really getting down low because my body is responding and it can feel the Suboxone now. If I take more than 2 milligrams, I can feel it,
Crazy, huh?
I didn't know that would happen because it was not intentional, but I thought that, 2 milligrams I thought would be enough for me to still not experience that, but it was not. It was like, I guess it's low enough in my system now to where if I was like, I'm getting down low. I cannot believe it. I'm actually kind of excited about it,
And what's happening, it's not the amount of Suboxone in your body. Remember, I've always told you guys, your architecture of your brain changes. Well, here's what's changing in your case. The number of receptors, mu receptors, are changing. So you need a lot less. So it's not even the Suboxone. The Suboxone allowed you to heal. Remember, I always say, as you've decreased now, and there's one other thing that's helping you heal over this time. The fact, and I know you pretty well now, and I know how active you are and how cognitively engaged you are in everything you do, the fact that you're exercising your frontal cortex as much as you are, that's changing everything rapidly. So it's all of those things, and then it's the Suboxone dose. So understand that you are actually changing heavily.
That is why. See, I didn't think I don't think like that. I think, oh, it's just because I'm on less of the medication, but it's because I'm actively, like you were saying that one day, you said, like doing the right thing and thinking about being honest. These are ways that we change that.
Exactly. Right. So, okay. Now, wow, you remember. Wonderful. So that's exactly, yeah. So you remember that. So here we are. So we're watching it. It's not just the dose. Your body has physically healed and changed without craving that opiate, because with subs, you don't need an escalation of dose. That's what addiction is. You need more and more. Well, when you put someone on subs, that's the beauty of it. Those receptors are filled. All the accessory pathways no longer are screaming at you. Now your brain goes about its business, and you can engage in real recovery, and with different people, depending on where they were at before, it takes different amounts of time. All of that is not bad news. So I'm so happy you remember what I said, because you just actually, what you said now displayed it. Your body actually can't take that much Suboxone. It's not that it's even in your system. It's going to get you high, and it's going to be, make you feel yucky.
And that's exactly what it did. I felt horrible that night. I had a splitting headache. It was nothing that I wanted to experience. Like, it wasn't like, oh yeah, I can do this and get away with it. It was like I had a migraine that was so bad, it felt like my head was splitting open. But anyway, enough about me. I got a question for you. Stephen wants me to ask you, will you please ask Dr. B what he thinks about methadone and pregnancy? The clinic wants, I guess it's his girlfriend, the clinic wants his girlfriend to go up, and she doesn't want to. She wants to be almost off by the time she gives birth.
By the way, hi everybody. I am so sorry. I usually try to read everybody one by one and say hello. I'm just I've been working, and I'm trying to make sure I answer all your questions. So hi everybody, and thank you for coming to see me on Nicole's channel. So why do they want her to go up? That's the question. And I would say, so methadone used to be first line for pregnancy. Suboxone is contraindicated because of the naloxone in it. Subutex is what you're supposed to use. So Subutex and methadone are the same. And my only question would obviously be better if you're on no opiates. I would say that if you are going to have to be on one during pregnancy, it's completely okay if the benefit outweighs the risk. And in that calculation, I would rather go with Subutex, which is a partial agonist, versus methadone, which is a full agonist. So those are my thoughts. And the question becomes, is the clinic wanting her to increase her dose because of a risk of relapse? And if not, then I don't see a reason.
Right. And talking about pregnancy and Suboxone or methadone, it's like, that's exactly what it's about. It's about whether or not of course I would rather be drug-free when I'm pregnant with my baby. But if I am living a high-risk life, if I'm out shooting heroin, if I'm snorting heroin, if I'm buying pills off the street, and being on Suboxone or methadone is going to be the difference between me being in those high-risk situations, that's why women get on methadone or Suboxone. It's not because, it's just like that, they just want to do it. It's because it's the lesser of two evils. It takes that risk away, and they can be monitored by a doctor. And I think a lot of people judge pregnant women that are on Suboxone or methadone, but really they're doing the right for their baby and for themselves by protecting themselves and being doctor monitored,
Absolutely. And I agree with you 100%. And I've participated in at least 10 deliveries, not being I've done a lot of deliveries in my past life, but I've been in there with I've taken care of patients that have delivered while on Subutex, and the babies are fine. One of them's 4 years old now. Fine. They're just fine. They didn't even go through withdrawals.
That's awesome. That makes me so happy to hear that, because I have a couple of girls that are pregnant that are on Suboxone, and that's one of their biggest fears, is that they're hurting their baby. And I was like, no, like, all I can tell them is that from experience working with other women, that I haven't had many people say that their babies have experienced any withdrawal. Most of them have none. Okay, next question. Here we go. Chicago Dave says, Nicole, is there any way you can ask Dr. B this question? I have chronic pain, and it's trigeminal neuralgia.
Trigeminal neuralgia.
There you go. I am on 110 milligrams of methadone daily, but when my pain is bad, I take more. The doctor will not help with pain meds. Oh God, why is my oh, I gotta charge my, hold on, Dr. B. I gotta charge my computer up. It's about to die. I didn't realize I didn't have it plugged in. Okay, got it. Never mind.
Take your time.
It's all good. Okay. So he says, where'd it go? I just lost it. Hold on. Sorry, Dave. I've got to find it again. Should I go up? I'm scared to. So did you get the whole question, or do you need me to reread it?
So he's on 110 milligrams of methadone?
Yes.
What?
And the doctor will not help him with any pain meds. So he wants to know, do you think he should go up or no?
So here's my thoughts on that. I'm curious why he asked trigeminal neuralgia. For those of you that don't know this disease entity, it's painful. It's extremely a nightmare, and some of these guys suffer. My first question is, how old is he, and why does he have trigeminal neuralgia? Understanding, and now here we go. My answer. Do you know where this patient lives?
Chicago.
Oh, Chicago, and his name is Chicago Dave.
Yeah.
I don't know how long he's look, for something like trigeminal neuralgia, because I know these pathways so well. I also know this disease entity extremely well. If his doctor doesn't want him to go up, or he doesn't want to go up.
Okay, he elaborated more. He says, I felt best at 285 milligrams, but tapered down to 40 milligrams when I got a job, but pain took me back to 110.
Here's what I have to say, Dave. So 285 is a good dose. It's a hefty dose of methadone. Now, trigeminal neuralgia, by the way, for you guys that don't know this, it's a trigeminal nerve. It comes from over here. It's one of the facial nerves, cranial nerves. There's 10 of them. Trigeminal neuralgia is an entity of initially unknown etiology. So it's a nerve. It has 3 branches, V1, V2, V3, and it's your eyes, and then over here, and then over here. When you get trigeminal neuralgia, all that means is an inflammatory response of the trigeminal nerve, and the trigeminal branch with V1, V2, V3 is a sensory nerve. So imagine, since it's coming in, it's an afferent sensory nerve, and when this gets inflamed, it hurts. Now, why does it get inflamed? So I don't know if he has a diagnosis for that. It could be anything from a tuber to MS to nobody knows. So he knows what the answer is. It's a horrendous disease. Now, if you look at the pain afferent pathways for this, Dave, I don't know how to say this. 285 is huge. That's going to knock you out. 110 starting to get there. You're already on this road. If it was my choice, I would have started Dave on Suboxone. And I mean, this is neuropathic-like pain. And there's somatic pain. There's visceral pain. There's neuropathic pain. And this falls under the category of neuropathic pain. And I am pretty certain, and some people, me and another researcher at UCSD have a good sense that Suboxone, buprenorphine, hits what's called NMDA, your ecstasy receptors, NMDA, which is a natural thing in the spinal cord. And remember, this is the facial nerve that's coming from your neck. I'm trying to keep it simple, guys. And
you're doing great.
Huh?
You're doing good.
Oh, and my sense is that Suboxone would do really well on Suboxone. Now that's a little difficult here because he'd have to titrate down to 30. He'd have to get someone to agree, titrate down to 30 milligrams or less, and then make that transition. So that's my first thought. My second thought is, going up while you're on 110, I don't know how much he wants to go up. 285 is pretty huge. It's going to zonk you out. but you're in pain, and I don't know how old you are and what else is going on. And if, I don't know why your doctor won't go up, but let's say all else being equal and you don't have any other issues, I don't know your medical history, and there's no concern for abuse or misuse or diversion, you're in pain and that has to be addressed. I'm not making a medical evaluation here. Those are my thoughts without knowing anything else about you, Dave, or what other mitigating issues exist. But again, this is a painful condition of V1, V2, V3, and because it's a neuropathic class of pain, as the pain doctors would call it, I think Suboxone would do really well on buprenorphine.
The problem is, I think, with a lot of people that have been on methadone for a while, is that it's hard, the transition from methadone to Suboxone, because it's a difference. But once you can get transitioned and balanced out and stabilized on Suboxone, I feel the pros of Suboxone outweigh the pros of methadone. At least for me, they do. Because when I was on methadone, I abused methadone. That's just me. And, I support any maintenance medication pathway. I support you guys. But for me, I was constantly trying to get that next, I was taking more and more and more and more.
Yeah, and this is why I'm saying all else being equal. When I gave that answer, I'm assuming Dave doesn't have a substance abuse history. If he does have a substance abuse history, I even am more pro switching over to subs versus methadone. Now we got a commingling of issues of substance abuse and pain, and it's real pain, whether anybody believes them or not. And then you're going to have to take the co-occurring issues of depression, anxiety, all that stuff that comes with that kind of. So, these guys get suicidal. I've seen that with this disease entity. So it's pretty complex. Dave, come out here and see me, and I'll figure it out. I figure most things out. Come out here, hang out for 3-4 months, and I'll get you transition over. I'm just kidding. Find a good doctor.
Okay, so Andrew says, how come Suboxone withdrawal lasts so long?
The data shows that actually Suboxone withdrawal lasts much shorter than methadone. People will say, bullshit, I've gone through these withdrawals, they're a nightmare. And it's easier than heroin. Now, here's the caveat, okay? But for those that have experienced differently, you have to have an equivalent dose of methadone and heroin compared to Suboxone. And here's why it seems like it lasts long or longer is this. How much did you taper off of? How quickly did you make the taper? And how long were you on it? So you'll get a heroin addict that comes in to detox, and which is something I never do in any of my programs. In fact, it's not even written for that. And they put them on Suboxone and taper them off in 5 days. And they're like, man, this stuff is a nightmare I don't even know why. Well, they make that switch because Suboxone is legal and it's safer to do that. But it's not really what Suboxone is for. You are already on heroin. I switch you to a legal substance, which is good, I guess, if you're dead set on being without any medication. That is not the reason why the withdrawal was a nightmare. And also remember, it has a very long lingering half-life compared to heroin and much longer than fentanyl. So that's going to add to that as well. But really, it's shorter than methadone because methadone, man, that stuff gets in your system and it builds up in your fat tissues. That's one of the things you do the first 5 days as you titrate someone up on methadone. And it's really an art for those guys that work in methadone clinics because you have to be really careful. It takes a couple of days for this stuff to equilibrate in your system, blood system, fat stores, and be back and forth even. So it's tricky. Suboxone is not as tricky, and the data shows methadone takes longer. But again, you have to realize how much subs were you on, how quickly did you taper, and what was your history before that?
I think that's what plays a big part in the stigma surrounding Suboxone, is that a lot of people that are tapering off of it or jumping off of it, they just jump off. And then they go around and they tell everybody, oh, I was in Suboxone withdrawal for 6 months. But they don't say, I jumped off 24 milligrams cold turkey.
Yeah. 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 Or they do it so rapidly.
Yeah, you have to tell, like, I've never realized how many, and I guess I used to do it too, because I'm one of those people who tells a story and it's like a grandiose story, you know, but when you're talking about medication that could potentially save someone's life, it's really important to include all of the details, so that way that person can get a good idea of, you know, we don't want to deter anybody from seeking treatment because they hear that Suboxone is going to be this awful medication that they're not going to be able to get off of, you know?
Yeah. Yeah.
Okay, so next question. You ready? Is it safe to take Klonopin while on Suboxone?
Great question. Who's asking? Melanie.
Her name is Melanie
Bailey. Great question. I got a quick question for everybody. I don't want to take away from time. Did anybody, including you, Nicole, see the 2 doctors that it went viral all over the world, 5 million views, that said, you know, it's time to get out of shelter and COVID-19 or whatever and go back to work? I don't know if anyone's been seeing that on Fox News, all the news channels. Elon Musk was texting about it or something. So I'm just throwing that out there. If anyone saw it, say yes, I'll tell you a funny story. So is Suboxone withdrawal, oh, I'm sorry, is Klonopin. So this is a great question. So if we take them in terms of class, opiates, sedative hypnotics, which Klonopin is. Opiates is within the class, Suboxone is the class of opiates, and Klonopin is sedative hypnotics. We do know that pretty good data shows us that your odds of respiratory depression and arrest, death, or really slowed breathing and needing a tube multiply if you have Klonopin on board. That being said, that's kind of out there that, you know, obviously you're going to get respiratory depression from both opiates and benzos. And so if you add opiates to the benzos, oh my God, no way. And a lot of, I think, Suboxone guys, I think they won't let you be on benzos, et cetera, methadone clinics. I think they're pretty cool. Here's the detailed truth of the matter. When you look at Suboxone, in fact, it was on your channel, somebody, Nicole, said their doctor wanted to bring him from 24 milligrams of Suboxone to 20 because they were on benzos. And I was like, what? Okay. So when you add something like buprenorphine, this really has essentially no effect. Because this is not something that's going to decrease your. Now, don't go out there and take a whole bunch of Suboxone, but Suboxone literally has very minimal effect on your respiratory depression because, as an opiate, simply because of that agonist-antagonist property, right? So, since you have that going on, adding the benzo. Now, I'm not recommending everyone on Suboxone should be on benzo. I'm just telling you the science of it. When you add a benzo like Klonopin, if it would be okay if medically indicated. 2, so that's that. It's not unsafe, really. That doesn't mean everyone should be on it. Number 2, if you look at most addicts, no matter what the age is, comes with that disease of addiction. A lot of these people I deal with, it's insane. The degree of anxiety I see in an addict, things that maybe it's my generation. I've had a pretty tough life myself, and I'm a little rough around the edges. But I'm watching these folks, and you would think that why is that causing you anxiety? Not very much causes me anxiety. I got other issues, but a lot of other issues. So these guys have anxiety, right? Number 3. Just coming off, especially early on itself, and getting adjusted sometimes causes a little bit of anxiety. So if you put all of that together, quite a few of my guys in my practice already came, and a lot of these guys also have polysubstance abuse. So there's there's one guy he was just one of, what do you call it? They call him like garbage cans. This guy's been inhaling everything since he was 12. He's 30 now, and the last issue was benzos and heroin. He came out of, I believe, Betty Ford, and I took him on as a patient 3 years ago, immediately put him on subs, and here we are 3 years later. I put him on subs, and now I'm not recommending this for people. I started him off on 40 milligrams or 30 milligrams of Valium a day, and because this guy was just chronic relapser, and every time he goes into detox, everyone's always like, well, whether it's Suboxone or not, the benzos have to go 10-day. You know what? We're at year 3. I have him now on 5 milligrams of Valium once a day. We went down from 24 milligrams of Suboxone to the equivalent of Subzolve, which is going to be, I think he's on 4 milligrams of Suboxone. Has his life back. We're at the tail end of it. Has his family. I went 3 years. He didn't have a single relapse. But my point here is a lot of these guys, you got to play with the benzos. Some of these guys come on Suboxone, and because of their severe benzo addiction, they start right off the bat. They're on, they're taking 10, 12 milligrams of Xanax a day. I switch them to Klonopin, Valium. If I have to, I'll go the Xanax route and high dose. Those I get down quickly enough to a safe place. But my point is this. Yes, if you need to, scientifically, clinically, you can do it. Of course, you got to watch for all the other things, and depends on the patient. If there's diversion, misuse, abuse, if they're not compliant. But when someone is really in the game and they're going to follow your lead, and I even do high doses when I need to. I get those down very quickly to a dose that I'm comfortable with, even if rarely I'll go with the Xanax. But if I see no other way, I'll go with it unless if they start screwing off. I've started guys on 6 milligrams of Xanax. I want to get down to 3 or 2 as soon as possible. Now I can slow down, and they're on the Suboxone. So, that I hope that answers it. You can be on both. The data says opiates, and in fact, there's some papers that show, yes, being on Suboxone and a benzo causes some respiratory rate decrease. But that doesn't mean clinic. You got to put things into clinical context from the scientific context. What does that mean? Okay, 3,000 people, let's say, went from breathing 14 times an hour to 10 times an hour after you put them on high dose of subs and some benzos. Okay, so what? And you have to interpret that data and make a good clinical decision that's also ethical and humane. Does that answer it? I hope.
Good. Thanks, Dr. B. Yeah, I always hear, people say that you shouldn't be on benzos and Suboxone or methadone, but it just depends. It just depends on the person. And compared to being on a benzo with a benzo with methadone compared to a benzo with Suboxone, the risk is lower with Suboxone, right?
Yeah, because methadone is a straight agonist. And I actually have one client who's in a methadone clinic that they're working with me to taper her down Suboxone. I actually have this one of the few people in my practice. She is on Xanax and methadone, but she started off at 150 or something, and she's down to 59 milligrams of methadone and my 2 milligrams of Xanax. And she checks in with me every week, and I assist them in titrating the methadone and all that stuff. So even with methadone, it just depends on the patient. You need to, as a clinician, I'm telling you guys, a good clinician, not that I'm good, but if they're good, they should make their decisions based on clinical decision making, not what something says. Of course, you don't do something insane, but you take those guides and you take the patient and then you do everything you need to do to make sure they're safe, and also you're treating them humanely, and then work with them, as this issue is very complex, guys.
Okay. Last night we had somebody come in the chat, and this is just my own question. What is there any studies or any proof out there that Suboxone makes your teeth rot out?
No.
Okay. All right. That's what I thought, but I had to ask. Okay. So we have another question from David. David says, if you take Xanax and Valium every day as prescribed, what does doctor think about long-term use of Xanax and Valium?
Yeah, I'm presuming the Xanax is going to be for panic attacks as an addition, rescue medication for the Valium. You know, Dave, it depends on your age and it depends on the dosing. And in general, I use benzos quite a bit. Don't like them though. Okay, you know, the long-term effect of benzos and the complexity of the number of systems they actually work on, and the possibility and potential for long withdrawal and chronic effects makes me not like them. But if someone desperate, but at the same time, I have guys that have been on 1 milligram of Xanax for 20 years every day, and they just have to be on it. And I even see changes in them. I don't like it in general, Dave. If I can get a guy off of this stuff, and or at the very least, if I can minimize the dose, and if I have to bring you in every week and we work together, and you know, I do have a couple videos on how I do these tapers. If I have to do that, you know, a lot of these questions revolve around really the same fundamental question. Some of these medications, a lot of these medications might be necessary, but the key is let's reduce the doses and make sure we're giving it to the ones that need it, right? And this is really the same thing. If you've got to be on it, can you reduce the dose and minimize the impact? But long-term effects, I don't like it. Again, depends how much you're on and how long you've been on it and how old you are. But the long-term effects are still yet to be determined, and it's a little bit different for every patient. Some have horrendous long-term effects that I see and hear about anecdotally, and some do okay once I get them off of it. Can you hear me, Nicole? I can't hear you.
Okay, I'm trying to find these questions. They're just going by so fast.
Yeah, you got that. Oh, wow, almost 40 people.
Okay, here's one. What to do? Okay, so how do you handle surgery if you're on Suboxone?
These are amazing questions. Hello? Yeah, can you hear me?
Can you hear me now?
Yeah, I can hear you. Can you hear me?
Can you hear me?
Yes. I can hear you.
Can you hear me?
Yes.
Can you hear me?
Yes.
Hello?
I can hear you.
Yeah, can you hear?
Yes.
Okay, so the question was, Diane wants Suboxone. What do you do? I'm lagging, huh? Okay. Surgery during Suboxone, or what do you do if you're on Suboxone and you have to have surgery, Dr. B?
Yeah, can you hear me?
Yeah.
Oh, okay. I think
damn, there's 40 people.
Yeah.
Okay.
I hope you can hear me because the channel's frozen. But boy, oh, it's not frozen. It's going. That is a great question.
I can hear you.
Yeah, I can hear you too. That is a great question, Nicole. And all these questions are fantastic. These guys have been reading clinical textbooks. But so new recommendations. Number one, what kind of surgery? Okay, that would be the first question. Nowadays, I'm getting more and more these guys to get the surgeon to give me a call, the anesthesia guy to give me a call, depending on the surgery. Again, if you're having a Whipple procedure, you're not even thinking about Suboxone. That's an 8-hour surgery. But quite a bit of surgery, especially outpatient ones, I manage it this way, and this is the new recommendations. You stay on your side, for a certain group of surgeries. Again, I don't know what surgery they're talking about. They just stay on their Suboxone, and they go in, and I talk to the anesthesiologist, and they add the fentanyl and whatever they're giving during the surgery on top of the Suboxone. They get out and pack in a post-recovery unit, and they give them whatever. And again, this really depends on what kind of surgery and how long it is. And then they go right home and get back on the Suboxone. I don't want to mislead. I just had one of my kids, not my kids, one of my patients, he's a young man. He just had a really bad traumatic accident and just shattered everything. He was hit by a car. So he had major surgery on his leg and was in the ICU. In his case, no, there is no Suboxone. He's on huge doses of morphine at home right now, right? And so what I've done in that case is I've gotten involved and I'm helping him titrate down off the morphine. And when the time comes, I'll pop him right back on Suboxone. But there's many of these minor and same-day surgeries that you stay on the Suboxone, get the opiates on top of it, go home, and you can really switch right back to Suboxone without ever having an opiate pill. It just depends on the surgery, and make sure they talk to a knowledgeable Suboxone doctor that knows how to do that and is comfortable with it. Can you hear me?
Okay. What about, does Suboxone affect? Yes. Does Suboxone affect kidneys and liver?
Give me 1 second. Does Suboxone affect kidney and liver? More, it's mostly metabolized through that liver. It shouldn't have too much effect on the kidney. It's peed out for the most part through the kidney. If you're saying so it's metabolized, so it makes the liver work. There's a system P, I forgot which one it is. It's a little too nerdy for me. P450, I could be wrong. It's a cytochrome system. So it's metabolized by the liver. So if the question does it affect the liver, is it harmful? No, not really. No more harmful than your opiate. Now, one little caveat there, and someone might go out there and be thinking about this. Naloxone, naltrexone can have toxic insult to the liver in theory, naltrexone. But even there, this dose is so tiny and it's inactive as soon as it goes under your tongue. So it goes and you pretty much pee it out. So don't get fooled by the fact that naloxone, naltrexone can be toxic to the liver. Those are people with already liver injury. What you will happen is if you're in child's or Pew class, if you're an end-stage liver disease or your liver is pretty much shot, you're going to probably have to be careful with your Suboxone, because now one of the pathways are going to be slow, and it's going to potentially pile up in your system. And a liver doctor is going to know that, because if your liver is that bad, you're in the hospital. So no, you're fine.
Okay. So thank you, Dr. B. I think what's happening is I'm lagging, but I think as long as I ask you the question and then be quiet, you'll be able to hear me. Okay. Okay. So next question, we were talking about this the other day. Somebody asked, does methadone, does it store up in your bones? Does it get in your bones?
No, it does. It stores in your fat tissue more than anything. And there's fat tissues in your bones as well in some ways. But that idea that it destroys your bones and it stays in there forever is a myth. But methadone does get stored, and over time it piles up. Okay, but that doesn't mean it doesn't equilibrate, and it's a dynamic back and forth in the bloodstream. In fact, that's why it's tricky in the first few days to get somebody on methadone, because you have to, depending on their kidney function, how quickly they pee things out, their liver function, and all of the systems, dynamic systems in your body, fluid systems, and the cell membranes, and how you are. It takes a few days and eventually adjusts, and you get this sort of dynamic equilibrium state that's back and forth in your bloodstream, and it flows that way. So, but the idea that it just stores in your bones and calcifies is a myth idea. Can you hear me?
Okay.
Okay.
This question is from Heather, and she's FN County of Santa Cruz. She's been practicing. Yeah, can you hear me?
Well, you kept breaking up, so I did hear County of Santa Cruz, which is near my.
You hear me?
I can, yeah.
Okay, I'm going to go ahead. Would you please discuss the risks and benefits of Subutex versus Suboxone?
Yeah, is this the same question as County of Santa Cruz? Because I missed the first part.
Okay. That was her question. She says she's an FNP at the County of Santa Cruz, CA, and she's been practicing MAT a year and a half now.
Yeah, I remember seeing this question.
Yes.
Yes. By the way, I'm from Monterey, just so you know. I grew up in Monterey, California. I used to hang out on 41st Street in Capitola and surf over there back in the day. I missed some of the questions, so let me do this. Give me 1 second, because I have her question.
Did you hear me?
Yeah, I can hear you. I have her question written here. Hold on. Give me 1 second.
Would you discuss the risk? Yeah.
Can you repeat the question one more time? Can you repeat the question one more time?
Yes. Here, let me find it. Yeah, hold on, Dr. B. Please discuss the, okay, here we go. Would you please discuss the risks and the benefits of Subutex versus Suboxone?
Yeah, what was there a relation to where she practices? Did somebody say something?
No, she said she was, it says that she was initially discouraged from prescribing Subutex over concerns of manipulation lending itself to abuse.
Right.
I do have a few clients who have this. You got it?
Yep, I get it now. So here's what it is. Again, this is historical, and it's a little bit bogus, little bit not. The way Suboxone came to be, Subutex is just buprenorphine, okay? And it's a pill, okay? So when this stuff in 2001, once the DATA, whatever waiver came and this stuff started going out, here was an issue that would occur sometimes. People would take, can you see me? I think you can. People would take the Subutex pill, break it up. The Subutex is just buprenorphine. They break it up, they crush it up, and then they would inject it, okay? So now, it's a diversion issue. The company Reckitt came up with Suboxone. They're like, how could we make this better and be a better marketing tool? Well, they put it in a piece of paper, right? They added naloxone in there, and here's how that works. And this is what creates so much confusion. This Suboxone, number one, who wants to crush up some paper? But people do anyway. Number two, the way that naloxone works is under your tongue. Once it goes into your system, it's not physiologically active. The body doesn't know it's there. But if you were to crush it up and shoot it up in your vein, now the naloxone, which was off, turns on in that setting and beats the buprenorphine to the mu receptor, and you can't get high if you were trying to get high off the buprenorphine, which is Subutex, to the extent that you actually get high off of it, which is for a short while for some people. Historically, that's how that came about. As their approvals and indications got slapped on them by FDA, Suboxone was initially approved for induction of this product, but Subutex wasn't. So that means you have to use Suboxone. You don't have to, but it's indicated for getting someone on this medication, and later on you can go to Subutex. So that's the history of it. And I go to 7 out of 10 practitioners, and they're like, "Oh no, I'm not using Subutex. No way." They're the ones that even know why the difference is. My thoughts on it: I couldn't care less what you want to use. If you're if there's diversion or if you're abusing, I'm gonna know. Whether I know today or whether I know in a week, I couldn't care less. And a lot of people I can give the benefit of the doubt. A guy comes in, I look at his cures report, he's been on Subutex for 3 years. Or a guy comes in, and a lot of people will bullshit you, BS you, and say, "Oh, I'm allergic to naloxone." And in their mind, they're thinking all kinds of reasons. They're thinking they might get high off the Suboxone, off the Subutex. Other ones think, "Oh, they're going to go into precipitated withdrawal with Suboxone, but not with Subutex." It's all wrong. If someone is actually understands this enough where they're using Subutex for abuse, okay, whether I know it today or I know it in a week when I start you on it, I'm going to know it. I'd rather try to get you well, and I'll know. I mean, that's what we all do, right? We're around addicts all the time. We're going to know if things are off. So over there, to our nurse over in Santa Cruz, feel comfortable with either one. There's one other issue you need to consider: people's insurance and affordability, right? Depending on what their situation they're in or what their benefits pay. You know, I'm going to take everything into consideration and make sure you get well. And I will know if there's something funny going on, but you don't see that much anymore. So that's the answer to that. Not much real difference. And the concepts of abuse, misuse, and diversion, if it happens, which is rare, you're going to know. And most people want the other stuff for a misunderstanding reason anyway. For example, they think they won't go into precipitated withdrawals with Subutex, but they will, because you're going into it because of the buprenorphine, not the naloxone.
Right. Okay. Does Suboxone cause weight gain?
I don't think so. Yeah, I don't recall.
I've gained weight, but I think it's because I've eaten a whole bunch since I got sober.
You get healthier.
Yeah.
You get healthier.
John Wolf says, "I am still experiencing pause 10 years after my last dose. Have you ever heard of this before?"
Sure. Last dose of Suboxone or opiates?
I'm going to say Suboxone, but I'm not sure. I think it's Suboxone. John, is it Suboxone or just opiates in general? I mean, pause can last different amounts of times for everybody, right?
Yeah. So this is wow. These questions are amazing. You guys have been studying like every topic I really enjoy. So again, I don't know this gentleman, but if somebody was going to say this to me in a vacuum, I'd be really curious. You know, LL being equal clinically and scientifically, you know, and I don't know. I don't want to put thoughts in his head because I'd have to talk to him to get to the root of it and understand if we're talking about, you know, here's someone, and this has nothing to do with intelligence. It just has to do with, you know, this is what I do. So, they might be interpreting something as pause, but maybe they have real insomnia or anxiety. So please talk to a physician. But if we are having truly pause, or maybe it's anxiety that wasn't there, or depression that wasn't there, or restlessness that wasn't there, and you've worked it out with a doctor and there's nothing else going on that needs to be addressed, and all of that is taken care of, and if we're talking about what you can maybe call pause, I would say this: Suboxone, buprenorphine is a powerful medication. Whatever was happening before to you that you started using maybe or abusing, just simply had some genetic or psycho. And I want to be careful about what I say here without knowing you, but I think buprenorphine really affects and helps with depression and anxiety. And you might be just one of those people that this stuff was elevating the mood, and maybe you needed to be on some minor low dose for life. Do not take that, what I said, as any kind of medical advice. I would have to talk to you. I would need 45 minutes, and I'm sure I could nail it and figure out exactly what's going on. But if we're going to assume there's some relationship here, I really wonder you're one of those with chronic low dopamine, and you might benefit from being on it. I don't know how your life is going and if you're managing it. But sure, you can have pause for 10 years, although it's not in the literature. Maybe it is now, but they had measured it 6 to 9 months. But that literature that I'm talking about is old. You can have stuff for a long time, and I would say it's not really pause. It's whatever got you on opiates in the first place. But again, disclaimer, I don't know your case, my friend. These are just some general thoughts I'm expressing. Don't take any of it as a diagnosis. You got to talk to somebody that really understands this, and go see them wherever you are, and sort this out. I can't hear you.
I think so too. I think that I know I experienced pause like. Can you hear me now? Why I'm lagging? This is really pissing me off.
Yeah. But go ahead.
Can you hear me, Dr. B?
Yeah.
Okay. We got another question from Diane. She says, people on Reddit are saying that Suboxone numbs 80% of your feelings. Is this true?
Absolutely not. Now, I do know people, for some people, at some point or earlier, in fact, I just got a guy off Suboxone, and he had been on it 5 years, and he said after year 3, it numbed, it sort of made him numb in terms of his feelings and who he was. And I believe him, and that's an anecdotal case. Anecdotal meaning it's a case that you know of or you heard of, and I know it. And you have to remember, there's always outliers in the spectrum of things. Most people, it helps with their mood, and I think most people, it helps with their mood and gets them back to normal. Does that do that for every single person? Look, guys, there's always going to be a certain percentage, maybe 2, 3, 4, 5, I don't know, 1. I don't know the data on this, but I do hear from certain patients it kind of numbs me out. I wonder what's actually numbing them out. There might be other things going on, but I have heard it. But if I was going to say, does Suboxone numb you up? Clinically and experience, I would say, on the contrary, most people might even be able to get off their antidepressant meds, and some of the, not most people, there's enough people that actually get off antidepressant meds and do okay on this if there's not other complex stuff going on, potentially. So, on the other side, again, I'm not saying you're going to get off your antidepressants, but I see plenty of that as well, which really convinces me that the literature that shows that there's some effect on depression is true for some people. But I think there's a small minority that I hear this about. But, to say it numbs 80% of your feelings, how did they measure whoever wrote this? What's 100% of feelings versus 80%? It's kind of a dubious claim. I do think some people have negative experiences with it. Can you hear me?
Yeah. I mean, I that for me, I feel all the time and I'm very emotional. And so, yeah, I can hear you. I'm lagging really bad and I'm sorry, Dr. B. Um, I I feel all the time and I feel all my feelings to an extreme. So, everybody's different. I think the way that each person's body responds to Suboxone.
Oh, Nicole just got cut off.
Okay, here we go. Would you please discuss the risks and the benefits of Suboxone versus Suboxone?
Oh, you can see me and hear me now? What was there a relation to where she practices when somebody says something?
No. Okay. Let me see how this
You can
goes.
see me and hear me now?
It's okay. I'll be back. Don't worry.
Wait, Nicole, can you hear me now?
No. Okay. Let me see how this goes.
See me and hear me now?
It's okay. I'll be back. Don't worry.
Wait, Nicole, can you hear me now?
Okay. Can you hear me?
Yeah.
Can you see me?
Yeah.
Okay. I clicked out and clicked back in because it's fixing to storm here, y'all, in Arkansas. So, it's just like literally turned black. So I think what's happening is my Wi-Fi is going out because it's fixing the storm. So let me see if there's any more questions. Oh, you can? Okay, good.
Yeah.
Let me see if we have any more questions. You guys drop your questions in the comments so that way I can get to them before me and Dr. B have to go, because if my Wi-Fi keeps dropping, I don't want to keep dropping the Wi-Fi. So let's go. Let me see if I can see any.
It's really clear now, Nicole.
Okay, good. Okay. I know for males, subs make you lose your sex drive. Oh, that happened to me too. Same. So do you hear a lot of people that come in and tell you that the side effects of Suboxone have been that their libido is low and that that they're not, they don't want to get their groove on as much?
Yeah. So long-term opiate use of any kind, one of the side effects is decreased testosterone. It's absolutely normal. And you got to remember, a lot of people were on other opiates beforehand anyway. So any opiate long-term use, one of the common side effects is decreased testosterone, which in a male is not just going to be libido, maybe fatigue, lack of energy. Very easily fixable if you've been on it for a long time or you have these symptoms. You just gotta go to your doctor and they do what's called, I think they usually do a free testosterone level in the morning, and depending on who, a little bit of testosterone cream, and you're back off to the races.
Okay. Thank you. Nicole, my friend Nicole says first of all, she's on methadone, and she says, I have another question. My psychiatrist has been trying all kinds of antidepressants, anxiety medications. Nothing is working for my anxiety. I try a very low dose of a benzo.
Can you repeat it? You broke up for 1 second. But
Did you hear that?
I heard most of it, but can you repeat it real quick one more time?
Yeah.
Damn, Nicole, I can't hear you.
Oh, yeah. My psychiatrist has been kinds of antidepressants, medications, looking for my anxiety. Should I try to get on a very low dose of a benzo?
Okay, so I think this person said, my psychiatrist has been trying all kinds of medication for my anxiety and nothing's working. Should I get on a low dose benzo? Is that what the
Yeah, I'm sorry, Dr. B. It's just, it keeps cutting me off. I know that's what it is.
That's okay.
She's on methadone and she just wants to know, should she ask her psychiatrist whether or not she should get on a benzo?
Yeah. This is a complex question, which only the physician who knows the patient can answer. But
this was cool. Here, I'll text it to you, Dr. B.
No. I heard the question. I heard it. I'm just saying it's a difficult question to answer because of its complexity. But I would, if the question is, should I ask my psychiatrist? Absolutely,
yes.
You should ask him. All kinds of people ask me that, and sometimes I say yes, and sometimes I say no. You have to know your patient and what you're going to start them on and what doses. And there's nothing wrong with her asking. I think the most important thing is you have to be, this still is the more important question is, do you have a rapport and a trusting relationship with your physician? And that's what this is. Can you hear me, Nicole?
Okay. Thank you, Dr. B.
Sure.
I hear you. Can you hear me?
Yes.
Can you hear me now? Okay. Is precipitated withdrawal from taking Suboxone too early doing the same thing to the body and the brain as when they put you under anesthesia for a rapid detox?
Too early doing the same thing to body and brain as they put you under anesthesia for a rapid detox. I mean, great question. But let me separate a couple of thoughts out for you. If we're talking about physically in the empirical reality, as you know, this is real. What is happening? Yes, you're flushing out the opiates, right? In this case, and they're left naked, right? So physically, it is doing the same thing. Really clinically. What the effect of that is at that moment is different, obviously, right? Because one, you're awake and now you're feeling all of that. The other one, you're actually sedated and all this other stuff. So you don't have the autonomic response that you do if you went under precipitated withdrawal, because they have you sedated and all of that stuff. So physically, yeah, you're pretty quickly taking the opiates out of your off of your receptors, depending how rapid the rapid detox is.
Okay. What I'm going to do is I'm going to put the questions on the screen, Dr. B, so you can just see them, okay?
Okay. Is that from Melanie? Is that the one you want me to answer?
Okay. All right. So the next question is from Mel.
Doesn't all Suboxone counselors supposed to have some kind of addiction themselves?
Yes.
It's kind of funny. So Melanie, I mean, when I say, I don't know how to answer that. It certainly is not a criteria to get your counseling certificate. They don't say you have to have been an addict, but I think most
are all Suboxone counselors supposed to have some kind of addiction themselves, or are they supposed to be in recovery themselves? Do you?
not by
look at my face. Look how it just froze.
yeah, you don't have obviously there's no it's not a law that you have to, you know, it's not one of the
Dr. B.
Yeah.
We've been on for an hour and 15 minutes. I'm gonna say I think it's time to call it a night.
Okay, this was fun. Great questions, guys. Hold on here. Yeah, I really enjoyed everyone's questions.
Hold on, be started. I'm trying to see your question.
Yeah, they had a lot of great questions. It was so much.
Okay, hold on.
Okay.
We did good, everybody, for being here. We'll do it again, you guys. Thanks, Dr. B. You guys, my internet is so crappy right now. If you could see outside, you would know what I'm talking about. Like, hold on a second. Where's my door? Oh, you can't see. It's just like fixing to crash down. Please, you guys, if you had any questions that I was not able to get to, please do not be upset. I'm going to put my my phone number right here, and you guys text me, and I will get those questions written down for our next live stream. Dr. B is going to be doing these live streams on his channel also. So if you guys haven't already gone over into his link, so that way you guys can come over and subscribe. We're doing the live streams on his channel every we did one last Sunday, I think. Yeah, we did one this last Sunday a week ago. So we'll do one not this Sunday, but the Sunday after that. So anyway, don't worry. I'll keep you guys informed. Let me get Dr. B's link for you guys, though. And I'm so sorry about my connection. It makes me so upset. Okay, here we go. All right. There's Dr. B's link. Seriously, if you guys have any other questions, you text me. I'll get them all together, and we'll all over to Dr. B's channel on Sunday and bum rush him with some more. And you guys know, if you need help or you need to see, need to get an appointment or talk with Dr. B, you're more than welcome to text me, and I'll help you any way I can to get that situated. Don't feel embarrassed or ashamed or shy or anything like that. All you got to do is reach out to me, and I will help you any way I can. You know, it doesn't hurt to ask, so you never know. You know, it might be something that I can, you know, help you out with. It might be something that I can get you connected with Dr. B for. So even if you're out of state and you're just looking for like recovery coaching, you can text me and I will see what we can do to get you hooked up. But I love you guys. And I hope you guys have a great, great day. I hate this computer. I'm literally about to take it and throw it in the trash can. But I want, okay. There's the phone number. Make sure you I love you guys so much. Thank you for being a part of Real Talk Recovery. And I'll see you guys tomorrow night at 7 p.m. Central Standard Time with Rob's Story Time.